Well, the first thing is they all need endocrine therapy. They all need adjuvant endocrine therapy. And this could be either with tamoxifen or an aromatase inhibitor if you're adding ovarian function suppression. So who needs ovarian function suppression? Well, based on the soft in the text trial, if you're which enrolled patients who were premenopausal, and they all had their ovaries suppressed with GnRH analog, and they were randomized to get either tamoxifen or ovarian and plus ovarian function suppression, or tamoxifen alone, or an aromatase inhibitor plus ovarian function suppression, you really saw the benefit of adding ovarian function suppression in those premenopausal women who are at high enough risk to warrant getting chemotherapy. So if you have a high risk premenopausal woman, and you could define high risk by their lymph node positivity because you know they need chemotherapy at that point, or if they're lymph node negative and they have a high oncotype recurrence score, either in the high intermediate or in the high risk category, these are the patients that require ovarian function suppression with either tamoxifen or an aromatase inhibitor. Now, how long will I give ovarian function suppression? If you look at soft in text, the standard was to give it for 5 years, but you do have some interesting anecdotal data. Well, I wouldn't call it anecdotal, it's prospective, but we haven't really all incorporated it. Is from the Astra trial that used only 2 years of ovarian function suppression. In my practice, when I'm counseling these women, I tell them the standard is 5 years of ovarian function suppression. But at the end of 2 years, if I find they're not able to tolerate it, and a lot of these premenopausal women, they aren't able to tolerate it, I say at least a minimum of 2 years based on the results of the Astra trial.